to AFEMSON 2021. Today is Wednesday, 14th of July. Prof, you can go ahead, ma, with sharing your slides.
Wait in a minute.
Okay. Today, Professor Falabi from the College of Medicine, University of Lagos, is going to be sharing with us the Dawes-Redman criteria for CTG supported by GNCI. Later in the day, we are going to have a workshop on anomaly scanning by the trio of Drs. Enabudozu, Awowole, and Akimoladu, and later the critical care course. For this morning's session, Professor Etuk is going to be the chair, and Dr. Aremu is going to be the co-chair. Professor Etuk, sir.
Thank you very much, Mayor.
Good morning, sir. Thank you so much for.
And good morning, everybody. Let me welcome all of us to this meeting. And like already analyzed to us, we have very important and very interesting, very exciting topic to handle. And I think it's a package that at the end of the day, all of us will go home satisfied. And to take off this morning is the Dawes-Redman CTG analysis that is going to be taken by Professor Bosede Afolabi from Lagos University Teaching Hospital, and with his associates. They are going to tell us what they have in package and all that we have to know. We know that CTG has been with us for quite some time, and that there are some areas, innovation they want to introduce now, which may be of interest to all of us and in the interest of babies and mothers. Once again, I welcome all of us, and I ask the team who are having the presentation to start. Thank you very much, and God bless. Prof. Man, you can.
Okay, thank you very much. Thank you, Prof. Etuk, for that kind introduction. And I will launch straight into it, as I don't think there's any protocols to be observed for now, except maybe to say good morning to the president of AFEMSON and the vice president, Professor Olufemi Kuti, and the vice president, Professor Saturday Etuk, and all other EXCO and as one of my chairs says, the title holders that are currently present. My name is Bosede Afolabi. I am a professor of obstetrics and gynecology at the College of Medicine, University of Lagos, and the Lagos University Teaching Hospital, which is based in the beautiful town of Idiaraba in Lagos. And I'm speaking today on behalf of JNCI, but I'm talking about something that is evidence-based, which is the Dawes-Redman CTG analysis. For, as a means of disclosure, Huntley owns the copyright for the Dawes-Redman criteria, and this session is sponsored by GNCI, which has a relationship with Huntley. And I will be paid an honorarium for presenting the topic. However, like I said before, it is a known evidence-based set of criteria. And as I go along, you'll see what I'm talking about. So why do we need these Dawes-Redman CTG criteria? We know that CTG is a very important, actually I should be showing my video, sorry. CTG is a very important manner of determining whether a fetus in utero is doing well or is how do I put it now? Is healthy in utero. We've also always known that antenatal CTG is actually the more evidence-based use of cardiotography monitoring, and we do use it, maybe not as much as we should here in Nigeria, partly because the machines themselves can be quite expensive, and also because we haven't been experienced in using them for a long time. So these Dawes-Redman criteria might even be a bit more useful here than others, and I'll speak to this. So why do we need them? Basically, the visual CTG trace interpretation is actually flawed, and the reason it's flawed is because we are very subjective in its use. We look at the CTG and we say, oh, this trace looks flat, or we say, oh, it's reactive, and we generally have limited memory capacity because we tend to remember, we can only remember so much. So if we've seen abnormal traces before, and we know that the outcome was bad, we don't necessarily remember how that trace looked. We're human. It's clear that we can't do that. So for that reason, we need objective methods of analyzing these CTGs. The NICE and FIGO guidelines and a lot of other expert guidelines are based on expert opinion, not necessarily evidence. And when I say they're based on expert opinion, I'm not saying that knowing that a trace is reactive and that it translates to a healthy fetus means that it's expert opinion. No, generally we know that evidence has shown that reactive traces tend to be to show healthy babies. What I'm saying is that the pattern recognition in each guideline is based on the experts agreeing that this is the pattern that we should look at, and I'll explain further as I go along. So there are many papers on the Dawes-Redman criteria, hundreds of them. There are more than these, and we can share these slides afterwards, I'm sure. And the background to the current use of the Dawes-Redman criteria is that the recent Saving Babies' Lives criteria, the recent Saving Babies' Lives document from the NHS, which was published in 2019, specified that human error in antepartum CTG interpretation has been identified as a significant root cause of stillbirth and serious brain injury. Human error in antepartum CTG interpretation. And it therefore recommended that the Dawes-Redman CTG analysis, which is known as CCTG, should be used to reduce the risks of human error. So, you know, even the most experienced clinician, if they cannot meet the Dawes-Redman criteria from their CTG trace, they would be likely to reevaluate their clinical assessment if that is the case. And it's been shown that if the CCTG, that is the Dawes-Redman criteria, is used for reduced fetal movements, it can reduce the number of scans required, because if the CCTG is normal, you don't need to scan the patient again and do the other parts of the physical profile as we tend to do on a patient's first visit for reduced fetal movements. Also, for when you're trying to diagnose fetal growth restriction or small for gestational age using the doctor's venosus Doppler, it's possible that if the doctor's venosus Doppler is not available, then the Saving Babies document recommends that we should use the CCTG. Now, we know we don't have all these packages here generally. We don't have a lot of centers that would do your DV Doppler for you easily and so on. However, if we got these machines, then these criteria, we would be able to use them in place of the DV Doppler and have an idea of how our babies are doing. So what does this Dawes-Redman CTG analysis do in particular? What it does is that it provides an objective evidence of CTG interpretation, and it allows using specific numeric facts instead of just opinion. And the output is either the criteria are met or the criteria are not met. And it's backed up by numeric data, which are measured from the CTG trace itself. So what happens is that the several CTGs have been entered into a system, and then an algorithm is made, which is entered into the system. And when you put your woman on the CTG machine and the CTG trace is being done, the algorithm is calculating from the actual CTG trace that it is measuring. So if you look at this, for example, I know that it's a bit small, but if you look at it, you will see that there's a trace here that is going wiggly up and down as the way traces can be. And just this short part that normally we would look at it and may not necessarily say, oh, this is a good CTG trace. Just this short part, the machine has already told us that the Dawes-Redman criteria has been met at 24 minutes. And it can even be met at 10 minutes sometimes. And it's because it is looked at several parameters and has decided based on those parameters that the criteria have been met. One of the most important things that one should do though when one is using these criteria and such machines is that the gestational age of the fetus must be entered into the machine before the tracing is carried out. So how can you regard the Dawes-Redman analysis? Generally, it's felt that you can look at it as your expert assistant. And what do I mean by that? In the UK, and I'm specifying the UK now because a lot of us do not look at that many traces these days, but ideally, an average consultant obstetrician would look at about 1,000 CTG traces in 1 year in the UK. Here in my center, I probably look at about 20 to 30 a month, which is not that many looking at the total, but it's still coming up to a full, maybe like 360 a year. And if I look at it over 10 years, I would need to remember, 3,600 traces in my head to try and determine which ones are normal and which ones are not normal. But how many of these can you actually remember? Much smaller number of them. Also, of the ones that you can remember, how many can we remember the outcomes? An even smaller number of them. So if as an expert assistant, Dawes-Redman analysis has a database of 100,000 traces. So it's like, if you are somebody in the UK, it's like 100 years experience. You can never, this particular analysis doesn't forget any trace. It knows all the outcomes and always applies the interpretation accurately. So that's the beauty of having this expert assistant. However, we have to also take note of the drawbacks. With anything that sounds fantastic, there are also drawbacks, because this assistant of ours is only an expert in CTG interpretation. This assistant does not know the baby. It does not know the mother. It does not know what the mother has been through. It does not know whether the mother has an infection. It does not know whether the mother has sickle cell disease. It just is an expert on that CTG interpretation, and we have to take its limitations in that manner. Now, how does it work? The traditional interpretation is a two-stage thing, and so is the Dawes-Redman interpretation. But for the traditional one, you form a subjective opinion, first of all, about the key trace features, usually your baseline heart rate, your variability, number of accelerations, decelerations, and fetal movements. Those are the 5 key things that those ones use. And then you now make a decision as to whether these features meet the criteria, whichever guideline you're using, whether it's the NICE guidelines, whether it's FIGO, whether it's NICHD, and so on, which we have said, those guidelines are usually based on experts sitting together and deciding which criteria to work on. Now, for the Dawes-Redman, it measures a much larger set of trace features, and there are about 14, and I'll show you later on. And then it applies a powerful algorithm. So it's not that it makes a decision based on, the expert opinion guidelines. It makes a decision using a powerful algorithm to these measurements to determine if they meet the evidence-based Dawes-Redman criteria. So if you look at the 5: baseline rates, variability, accelerations, decelerations, and fetal movements. Whilst for the Dawes-Redman, it has signal loss. It actually gets you the percentage signal loss, fetal movements per hour, contractions, moves per minute, basal heart rate, everything written here. The Dawes-Redman goes through them, and now about 14 different criteria that it looks at to make its decision. Sorry, I'm just trying to see. I saw some chats. I was wondering if there were any addressed to me. No, there aren't. Okay, so this is an example of a Dawes-Redman, a CTG trace using the Dawes-Redman criteria. So if you see this CTG here, there's a deceleration here, as you can see, and there are some accelerations, and you can also see certain, the baseline fetal heart rate and so on. So it's interestingly, you know how it is that we give these kick charts and we ask the mother that, by the time, the traditional way was that after 12 hours, they should have had 10 movements. I mean, obviously, as time went on, that was amended, even though people still say the 10 in 12 hours thing. But you know that you can have all those 10 kicks in 1 hour. And actually, in both, the fetus moves much more than 10 in 12 hours. In fact, much more than 10 in 1 hour. So if the woman is actually pressing the movement monitor at that point in time, this particular CTG has seen that the baby moved up to 85 times in that 1 hour. Basal heart rate was as written there, contraction peaks and so on. And within the first 12 minutes, the Dawes-Redman criteria were already met. And of course, when they finished it up to 60 minutes, it was definitely still met. But one thing that is clear there is, and it always states clearly, is that the analysis is not valid during labor and that it is not a diagnosis when it says that the criteria are met. So looking at comparing the two again, the traditional is subjective opinion, and there are many variations and different trace formats, whilst the Dawes-Redman has been ongoing, collecting evidence for over 40 years. It's the largest evidence base of its type, over 100,000 traces, over 100 peer-reviewed papers, and many years of enhancements based on feedback and continued research. I saw one paper when I was researching into it, because I wasn't just going to collect these slides from GNCI and now start saying, okay, this thing is fantastic. So I did look into it quite a bit myself. And I saw one paper that said, you can't really trust the Dawes-Redman criteria for some reason. And the reason was, the conclusion was that in diabetic mothers, there are certain errors that, it can give you. So that's why it's important to actually look at the errors, the limitations, look at the patient holistically, know that in certain conditions, you have to be careful with interpreting the trace or what the interpretation gives you. So when you are trying to apply the criteria, the first result comes out after 10 minutes, okay? And in those 10 minutes, it can actually tell you that the criteria are met if they are met. But if they are not met, it will continue analyzing every minute. If after 60 minutes, the criteria are not met, then it will tell you that the criteria are not met, and then you can now make your own decision. So there are three possible outcomes. You can have the criteria are met, you can have criteria not yet met before, when it's not yet 60 minutes, and by 60 minutes, it tells you that the criteria are not met. And there's a reason for it waiting for up to 60 minutes. So I'll speak to that later on, but generally, when the criteria are met, you're advised to just say, fine, let's stop this trace. And the reason is because the evidence of normality is quite high and you avoid wasting time. And also the ALARA principle, which says that, you should use ultrasound only as low as reasonably achievable. And we know that, Dopplers and CTGs also work using the ultrasound technology. So the shorter time you can use to use the ultrasound, the better. It saves time. And in a trial that looked at over 6,000 traces, it showed that it saved up to 1,500 hours in time, which is huge. Now, the issue of the indication of a reactive trace. You don't actually have to have acceleration before you say that a trace is reactive. You can use other indicators that are present, and the Dawes-Redman does that for you. And there's also no need to review the numeric data. The computer has done it. The only difference is something we call short-term variation, which is a slightly different concept from the general variability we look at, in terms of the fact that it's using a much shorter time, which you can't see on the trace. So the Dawes-Redman can calculate that, the algorithm can calculate that, but it has to be up to 60 minutes before it can calculate that. So the criteria generally, when you're applying them, it's still subject to you eyeballing, just to be sure, it looks okay. And also, more importantly, your clinical judgment based on a holistic review of the patient and the whole pregnancy. And if you look at everything and, it's going with what you think, the patient is, there has no risk factors, the visual thing also looks good. Once it's 10 minutes and the criteria have been met, you can stop your CTG monitoring. Now, when the criteria are not yet met before 60 minutes, the reason it is 60 minutes, let me speak to that now before continuing with the rest of this slide. Now, we have this sleep pattern that we talk about in fetuses, even though it's not as if they're actually sleeping, but they do have a sleep pattern in their fetal heart rate variability, or fetal heart rate, variability. And even though traditionally it's been said that this sleep pattern within 40 minutes, it should be over, Dawes-Redman has shown that it can actually take up to 60 minutes before the whole cycle, before you go through the whole cycle. And if that is the case, it's possible that if you started your trace when the sleep cycle was just starting, then you may not get to seeing what the fetus does properly until 60 minutes. And that's why it's important to wait 60 minutes if the criteria are not yet met. So unless there are clear pathological features, you can wait until that 60 minutes is completed. However, if you are already seeing some really bad things on the trace, you already feel that the woman, maybe she's febrile or she's having a discharge or something, and it's telling you to wait till 60 minutes, but you feel that no, it's not okay to do that, then of course you can stop the trace before the 60 minutes if you're really in a rush. But it's better to avoid premature termination of the trace when there isn't a good normality, as it were. Now, there's this other thing that people may shake their heads a bit at. Sometimes, although not commonly, the Dawes-Redman analysis may change its mind. So it could meet the criteria within a short time. And then as you continue, if you do continue the trace, it could now tell you that the criteria is not yet met all of a sudden again. And there are two reasons for this. One of them is because once in a blue moon, something can change very rapidly in pregnancy. You may have a fetus that suddenly tie itself in a knot and, there's a problem. So something has actually truly changed. On the other hand, it may just be because of the way, these algorithms work. So if it is based on single figures, if the true value is 3.5 and it's recorded as 3, when you have 3.6, that will be recorded as 4. So that small change between 3.5 and 3.6 can look like a very much bigger one because one is recorded as 3 and the other is recorded as 4. And for that reason, a borderline trace may now seem like it's not yet met. If this occurs anyway, what to do is to note that if the fetus or mother seems to have a particular problem, then continue the trace. Otherwise, you can accept the first analysis. But I think it's safer, especially when one is just starting, to just continue the trace and be sure that everything is okay before you now discontinue. It's better not to stop the criteria stop the recording before the criteria is met. It's just like a waste of time. So it's best to just wait. If you know you're going to start it, you might as well just wait until it finishes and not just stop it prematurely. So if the criteria are not met, that is after you've done your full 60-minute analysis, you have the situation that the criteria are not met. The good thing is that the reasons for the failure are shown on the machine. And in the context of an antenatal CTG, at best, it could just be that it's a non-reassuring trace, or at worst, it could be something bad, like a pathological outcome that is causing the criteria not to be met. So you have to be ready to analyze what's going on, decide whether, based on the reasons for failure, you are going to move to immediate delivery, or still monitor the patient accordingly. But once the criteria are not met, you need to know that it's telling you that this is a non-reassuring trace at best, or at worst, it's telling you that this is a pathological issue going on. So just one other thing that is important is this short-term variation issue. Now, short-term variation is something that can only be calculated by computerized analysis. It's different from just the variability that we talk about, whether when we say this is a flat trace or this is not a flat trace. Short-term variation is different. And what it is that short-term variation is looking at the change in bit to bit, sort of like every 3.75 seconds is looking at the change in the heart rate at that time, because the fetal heart rate changes that quickly. You cannot determine it visually. It has to be the computer that analyzes it. And before 60 minutes, even the computer can't do it that well. So it's important to note that it's the computer that analyzes this. Now, another point about it is that oftentimes short-term variation less than 3 milliseconds is strongly associated with fetuses at high risk of metabolic acidemia or intrauterine death. However, when it is greater than 3 milliseconds, it does not mean there is no risk. So you still have to review your whole analysis. This table shown here is telling us about two studies that were done from at Oxford of compromised fetuses specifically. They were looking at compromised fetuses. And as you can see here, the short-term variation changes based on the gestational age generally. So for a certain group of fetuses that were 25 to 38 weeks gestation, and the STV was less than 2.6 milliseconds, it was found that the intrauterine death in those fetuses was like 24%, whilst in those that it was between 2.6 to 3 milliseconds, the intrauterine death was 4.3%, and those that were greater than 3, the intrauterine death rate was 0%. However, I must say again that it doesn't mean that anyone that has greater than 3 is not going to die. This was looking specifically at fetuses that were compromised, and it was just a particular study of two different sets of fetuses. So these are some of the reasons for not meeting the Dawes-Redman criteria. Basal heart rate outside the normal range, large decelerations, no episodes of high variation, and so on and so forth as written here, high frequency sinusoidal rhythm. And another thing I like this criteria for helping with is sinusoidal rhythm, because it can be very difficult to see on a trace for, unless you're really used to it and very experienced with CTG, when a rhythm is sinusoidal and when it isn't. So this machine being able to calculate that, this algorithm being able to calculate that is a very useful thing indeed. So these are some of the reasons why the criteria are not met. And to get the maximum benefits from these analyses, it's important to adapt local protocols. So for example, if you had, most local protocols will tell you you should do your tracing for at least 30 minutes first, or at least 40 minutes first. But if you now adapt your protocols using this, saying that, look, you can do it for 30 minutes, but if the criteria are met, then you can stop, then that helps save time. It's important to engage with all stakeholders on it before you can change your practices, obviously. It's important to train users, and it's important to escalate it to all the different stakeholders as required. So when do you use the Dawes-Redman criteria? It's the same time as for an antepartum CTG, that is from 26 weeks usually. Some people use it earlier, but it's better to just start from 26-week gestation as the earliest time. you can use it up to the start of labor, but not when labor has started. Whether latent or active phase is not accurate during labor. It's for antepartum CTG. Please take note of that. If you're going to use it for induction, it's before you start the induction. You know, maybe you have a patient, maybe you have a small for gestational age patient fetus that you want to induce. So before you start the induction, you use your Dawes-Redman to tell you that, okay, this baby seems like it's okay. And after that, it's not accurate anymore. There are no contraindications to it except that it must be used prior to the onset of latent phase or active phase of labor. It is not to be used only for high risk management. That's another thing. Sometimes when we get these tools, we feel that we will only reserve it for high risk fetuses. You shouldn't, because then it's not as useful, and it also would give you a high sense of fear that, oh, this thing must be used very carefully, must be bad because this baby is very unwell and so on. It's important to use it generally for low risk as well as high risk, and then it can help you make your decisions more accurately. So these are some of the supporting material for this. Professor Chris Redman is a very well-respected UK obstetrician and gynecologist. There's the website, Huntley website has a lot of the documents required, and I thank you very much for listening. Thank you.
Professor Tukta.
Thank you very much, Prof. That was a wonderful presentation, and I think it's very educative as it is. I guess people must have posted some questions in the question box, and I urge the Professor Additional, if you have the questions, can you help us read the questions and the persons involved so that it can be tackled?
Okay, thank you, sir. Well, although there are no questions in, yes, Professor Amako has put a question here, that how often can this be done for a patient? And then I think I will add to that. Yes, I think maybe while Prof is answering that, other questions may come in.
Okay, so regarding how often it can be done, the same amount of time and the same frequency that you would do the traditional CTG. So if you are asking a patient to come in for daily CTGs or for every other day CTGs, you would do the same thing. You would do it as frequently as you would for a normal antenatal CTG. So for example, such patients, maybe you have a patient with IUGR, and you want to, it's getting to a case where maybe you can't do your doctor's venosus Dopplers. You've seen that she's still maybe about 28 weeks. You want to buy more time, and the umbilical artery Doppler is abnormal, for example, but not too abnormal. You want to just monitor more carefully so as to know the exact time, have an idea of when you can't go further, then you can use it daily for such patients. So it really depends on how worried you are about the patient, and that's when you can use it, and that's how frequently you can use it. Yes, somebody asked if this makes use of big data, artificial intelligence. Yes, in a way it did, because maybe the person joined late. So about 100,000 CTG traces were entered into this machine. And when I say traces, it's not as if they fed the trace itself. All the parameters of the traces were captured. So including the short-term variation, the number of accelerations, the number of decelerations, the baseline heart rate, the the high episodes of variations, so many different things were entered into a computer system. And yes, artificial intelligence was used to create an algorithm, and that was now fixed into in the computer system of the CTG machine, and that is what is used to make these decisions. Now, it would be nice to have more. How do you become worried? When do you become worried? It says, well, basically, if the criteria are not met, okay, that is when you become worried. If the criteria are not met after your 60-minute CTG tracing, criteria are not met, you now tie it together with your fetus. So you have this fetus, small for gestational age fetus, for example, and criteria are not met, and you know that this fetus, the umbilical artery Doppler is already giving you issues, you probably decide that, okay, maybe I should go and deliver this fetus. Or if you have a patient that just says, I have reduced fetal movements, okay, criteria are not met, it's telling you that that's not reassuring. But if everything else is fine, you may not say, okay, I'm definitely going to deliver now, unless the fetus is already of a reliable gestational age. So those are some of the ways in which you can use it. Somebody says it would be nice to have more training sessions on this. Well, I'll leave that to and the machines if possible. Why can't this be used in labor? That's a good question. I think that what the problem must have been is that when we know as it is that CTGs can be quite unreliable in labor, because if you use it alone without using fetal blood sampling, then you have a very high incidence of cesarean section, because there are a lot of false positives. It's not as specific as it should be. And I think maybe when these criteria were entered for labor CTGs, they probably found that it wasn't also as specific as it should be. And that's why it's not used during labor. Let me see. Apart from the 3 outcomes, does it give? Yes, it gives reasons for criteria not met, but it can't pick signs of cord compression. It will just give you the reasons. Okay, so I thought you meant just saying the algorithm telling you there's cord compression. No, it will tell you that the number of accelerations are not enough, or there are no movements, or it will give you the reasons. And there was one slide, let me try and go back to that slide, that tells you about these are the reasons, some examples of reasons why the criteria have not been met. So no accelerations, suspected sinusoidal rhythm, possible error at the end of the record, short-term variation is less than 3 milliseconds, and so on. So how easily can this be deployed to private facilities, generalist use, and possible collaboration with tertiary centers? Well, I think basically we'll have to, the unfortunate thing about this, and I have to say this about it being unfortunate, sorry JNCI, is that it is actually on a specific machine, I think, because Huntley has the copyright, to be able to use this as a fixed algorithm, you would need to get that machine. And I'm sure that machine is not cheap. So I think it's one of those things that has to be looked at as, the benefits outweighing the risks. I'm sorry, the cost benefits ratio, sorry. The other thing is that I'm not sure, and maybe JNCI may speak to this, whether the algorithm is available on its own. Somehow I doubt it. I think that it is only incorporated into that machine. Maybe at some point when that can be divorced from it, then it can be used on its own independently. I don't know if there are any other questions. Basically, the use is that I think one has to buy the machine in order to be able to use the criteria. But I'm here basically to speak on the criteria. I can't see any other questions. Thank you.
Thank you so much, Professor Balabi. Professor Tuksa. Okay, I'm not sure if Professor Tuk is still with us, but we will still part of this session. We're going to take a 10-minute presentation from GNCI. I think they want to demonstrate the machine to us. Precious, are you here, please? I can see you on. Dr.
Yes, I am.
Okay, so please, can you go ahead with your presentation? We're already running late into the period for the next presenters. Professor Falabi, we want to thank you so much for that. I think definitely more sessions on this. It has been quite interesting. This is what you can do with big data, artificial intelligence, and you can hopefully make more out of the information available to you. So maybe you can should Prof on share a screen while you share yours? I don't
Okay.
know.
Done.
Thank you. Thank you so much, Matt. That was quite instructive and interesting. So we look forward to, I think we should have, AFEMSON will organize maybe with GSM more sessions on this. It was really very interesting. And Precious, please go ahead.
Thank you very much.
Okay. Thank you very much. Thank you very much, ma'am. Thank you very much, Professor Folabi, for the insightful presentation. Good morning, everyone. My name is Precious Wanganga. I'm Sales Specialist General and Emergency Medicine for JNCI. I have a confession to make. The very first time I happened to be in the labor ward, that was the first time that the CTG device was being used live on a patient, and I got to see firsthand how good and how effective this device can be in helping physicians with their diagnosis and with patient management. Honestly, it was just simply transformational for me, and it was really fulfilling getting to see how this device can add value to clinical practice. So I'll just go quickly over my slides. I know that I don't have so much time. Basically, my brief presentation is talking on advancing fetal maternal care with enhanced solutions. So just a little bit about JNCI. We're a proudly Nigerian turnkey medical equipment solutions company. We have an employee of over 102 core staff, a 27-man technical team. We're exclusively partnering with over 28 global leading manufacturers, and we have an international call center, 24-hour call center, attending to clients' needs. We have a value chain crossing across the entire spectrum of the healthcare chain: intensive care units, emergency medicine, cardiology, surgical and medical wards, operating theater, etc., etc. So looking at fetal and maternal monitoring solutions in particular, here we have three range of products, one of which happens to have the exclusive algorithm which Professor Folabi has extensively talked about in her presentation, which is the Dawes-Redman algorithm. It's the Sonic 8 Team 3 Advanced Fetal Maternal Monitor. Now, this device is embedded with the Dawes-Redman algorithm. Just to respond to a question someone asked, if the algorithm is available to other CTG devices, or if it's as a standalone software. Sadly, no. The Dawes-Redman algorithm is exclusive to the Sonic 8 Team 3, which is the device over here on my left, the left side of my screen. So the Team 3 Advanced Fetal Maternal Monitor is a CTG device embedded with the Dawes-Redman algorithm, and it also is capable of monitoring triplets at a time. So unlike other CTGs that are either twins capable or single fetus capable. We also have the Sonic 8 BD4000 XS twin fetal heart rate fetal monitor, which is on my right, and the Sonic 8 SR2R fetal Doppler. So the new Team 3 series is a cost-effective, reliable solution for accurate fetal maternal monitoring. It also has an automated Sonic 8 actogram and maternally sensed fetal movements. It's triplet capable ultrasound monitoring, enables doctors to monitor triplets at a time. So even if the mother happens to have 3 fetuses, the device shows all the parameters for the 3 fetuses at the same time. It also has dual fetal movement markers, a manual one held by the mother and an automatic one by the device itself. It also has a high performance audio for the most sensitive fetal heart detection. So you get loud feedback of the fetal heart rate as it beats from the device, loud and clear. And like I mentioned, it has the latest, most powerful release of the world-renowned Dawes-Redman CTG analysis software. It is mains and battery operated. That means it can run as a standalone device without connecting to a power source, and it can also work as connected to a power source. It also has an integral patient database with trace memory. So every trace that is recorded on the device, it has a memory to store up all the traces that were run. So the clinician does not need to manually record the traces. The device keeps a record of all the traces of patients run throughout the clinic. So even for reference purposes, the clinician can always refer to the records or even download or extract the data and use it subsequently in patient review. And then it also has maternal blood pressure and SpO2 measurement options as well. Some additional features, as referenced in Professor Afolabi's presentation, is the Dawes-Redman trace interpretation. It's flexible, it's scalable, it's multilingual, and it's customizable as well. These are some of the advantages of the Team 3 CTG, which is our focus product for fetal maternal care in this conference. We also have a range of other products, which I'll just highlight briefly, which are relevant to fetal maternal care, which is our delivery and labor solutions. Now, this particular solution is our Agile Birthright labor delivery and recovery bed. It's a convertible bed that serves as both a labor delivery and recovery bed at the same time. So it's convertible, it's foldable and adjustable. So it quickly converts from a standard bed to a versatile delivery platform, allowing for safe and comfortable delivery. Next, we have our infant life care support solutions from Phoenix. This includes our intensive care incubator, the INC 100, and our neonatal care resuscitation center, the NRC 100. We also have our Brilliance Pro phototherapy unit as well from Phoenix. Next is our maternal life support solutions. So here we have patient monitoring solutions from Sheila, which include the TrueScope Ultra Q5 monitor, the Touch Mini monitor, and then our Vanta Science monitor from Huntley as well, and the Smart Science handheld pulse oximeter from Huntley Diagnostics as well. And we also have our Defiga HG7 defibrillator solution from Sheila. So wrapping up my brief presentation, like I mentioned, it's important for us to embrace the technology as it advances. So we see that we've moved away from subjective analysis to objective analysis based on evidence and based on algorithms. So there's minimum guesswork and there's also reliance on data. As we all know, technology has evolved and made life easier by reason of big data, artificial intelligence, and the rest. So I want to encourage us to take advantage of this and key into the fetal maternal solutions, the Team 3 solution from JNCI, which is embedded with the Dawes-Redman algorithm CTG analysis software. I think there was a question someone asked if the Team 3 device can be deployed to private sector, private hospitals and the government hospitals. Yes, it can. As a matter of fact, a number of private facilities have the Team 3 device across the country, and also a few government facilities as well. So it's not restricted to a particular kind of facility. So whether it's a public sector or private sector facility, you can take advantage of our solutions and deploy them to your needs. So if you have any questions, feedback, or you want to know more about our solutions, please feel free to reach out to me, and I'll be very much obliged to respond to your questions, inquiries, and requests. Thank you very much.
Thank you so much, Precious. Professor, please go ahead, sir.
Thank you very much, sir. I think the time spent is worthwhile. Let me apologize profusely for my network challenges moving from here to there and all that. I pray God will help us out. I think the time is well spent. I think all the questions have been handled. Let me use this chance to thank the presenter, Professor Bosede, and the last chap that presented for those decent presentations. And I believe we'll look at it as obstetricians, neonatal